And I'm the Integrated Behavioral Health Manager for the Spokane Regional BHASO, and I will be helping to facilitate today's Spokane Regional Interlocal Leadership Structure or SCRILS meeting. So thank you all for joining us. And if you haven't done so, please put your name, role, and organization in the chat. That's how we're keeping track of attendance today. So happy Friday, everyone. We will go ahead and get started. I believe we have some representatives from the state on to give some updates regarding 988 and general updates from the Healthcare Authority. She's not there. Is she?
And just double checking to make sure that we have the chair of our board. Commissioner Cooney, are you on the line?
No, she's
not. And not hearing or seeing Commissioner Cooney. Facilitation for the meeting generally falls with the chair of the Board of County Commissioners of Spokane County, but we will be filling in for her big and wonderful shoes. She had a busy night last night and I believe is traveling. So Ashley will be taking point on facilitating today.
Thank you, Justin. And from the state side, I didn't know, I see Katie on there and I see Martha Abby on there as well. Not sure if HSA or DOH wants to take it away.
So I'm from DOH and I can give my update first, if that's okay. Is it okay if I share my screen? I just have a couple slides just to visualize what I'm going to talk through. Okay, perfect. Let me do that. Okay, so I guess I'll start out. Just thank you for having some time on your agenda today to share some updates. My name is Katie Lindstrom, and I am with Department of Health, and I'm working in the 988 section. And my primary functions are right now are to help with the 988 and RCL transition process, and also helping to coordinate the 988 hub designation process. So both of those are actively happening right now. And we've been doing outreach with different groups, including the ASOs and 988 centers and others. And so wanting to kind of get out into communities as well and just share and provide updates on where we're at with both of those processes. So first of all, just as a brief, I'm sure people in the room know this, but current state right now, the RCL map looks like this. This is you guys over here. And this is what the 988 centers look like right now. So there are 4 providers for RCL currently across the state. There's 3 providers for 988 across the state. In the future state and what's going to be happening with the hub designation process is the RCL providers won't change. That lives in the ASO world. But the 988 contact hubs, that's what's kind of currently up for possible redistribution. It may end up looking the same. It may end up looking a little bit different, but that's what we're working on right now is to determine who will be the 988 hub providers throughout the different regions in Washington. Really quick update on the hub designation timeline. I'm sure all of you are aware, back at the end of July, hub applications were due. And so we did receive 5 applications across the state. There was 2 applicants that proposed to serve the region that you all are in, including the current provider and then a provider called Protocol. So we have been working to review those applications. We have a scoring rubric that we're using. We also have been collecting recommendation forms from each of the ASOs, including Spokane, to find out what their recommendations are on the applicants. We've also received recommendations from HCA on each of those applicants. And over the course of September, the committee that's reviewing will be kind of compiling all of that information and coming up with a recommendation that will go to our leadership here at DOH for a final decision. And the goal is to have that decision by the end of October. Although the hard deadline is the end of the year for designation notifications. So just a quick update kind of on where we're at with that application process. The other piece that I mentioned that I'm working on, and it kind of goes hand in hand with designation, is just the whole transition, the 988 and RCL transition. In the future state, based on our call volume estimates, 988 call volumes are going to increase about 235%. And that's because calls from individuals that currently individuals call in, and they can call into the RCL or 988 to get support. In the future state, the individual callers are going to be directed into 988. And the RCLs will continue to handle all of the professional calls from law enforcement, behavioral health providers, and whatnot. And they're also going to continue to handle all of the dispatch. But because of that shift in individual callers moving over to 988, that will result in a 235% increase in calls for 988. And again, RCL is still maintaining a significant portion of calls, but basically kind of handling all that transition and then how the different systems are going to work together. That's all kind of what's included in this transition plan. Also onboarding any new hubs, if there are new hubs selected. Again, it's possible that the three hubs that are the three centers that are currently providing 988 may continue, which would make transition a little easier. But if there are new hubs, transition is going to involve onboarding. It's going to involve figuring out new protocols and ways to communicate between the different system partners. So there is a transition action plan in draft form right now, and we are working to continually update that, hoping to have a second draft done by the end of September. We have shared the draft action plan with the ASOs and with other system partners. So we are trying to actively get input into that plan and make sure that um, we're hitting the mark with planning and we're not missing anything. So we do look forward to getting back some edits from our ASO partners and others soon on that plan so that we can finalize that. And this is just kind of a bigger picture kind of timeline. We've had a lot of questions about transition and how long it will take. Questions like, currently, there's a public number for RCL or for people in the community to call the RCLs. So the big question we've been getting is when will that phone number no longer go to the RCLs and instead divert to 988? So that's a big question. This is kind of just a big picture timeline. So between now and the end of the year, we're really working on designation and figuring out which providers are going to be the future state providers. We're doing a lot of data review. I had mentioned call volumes. We're looking at call volumes quite a bit and also call volumes by type of call to kind of figure out which percentage of calls are going to stay with RCL versus move over to 988. And using that to do some budget projections to kind of figure out what's going to make sense money-wise. On money, that is a pretty big question mark right now. There's a pretty significant budget shortfall at the state level. And so we don't have, as of today, we don't have solid numbers from the state, from the higher ups. And so we're kind of working on this process. And then at the same time that the budget is getting figured out. So that also is going to affect the number of hubs that we can designate and some other things. So as I'd mentioned, as of the 1st, that's when hubs will be designated. Once we have our hubs designated, we will be reaching out to each hub and region that they serve and developing an individualized transition timeline. We know that there's some regions that are going to be more ready to move forward than others. And we also know that there's going to be some providers that would be more ready to move forward than others. And so we're really going to be approaching this with some flexibility and just develop those transition timelines on an individual basis based on, the capacity and the needs and just kind of where the different providers are at and also where the different regions are at. So that work will begin in earnest in January. We'll also be obviously finalizing contracts, budgets, scopes of work, all of that sort of thing. And then continuing to do just a lot of outreach and engagement. The transition plan that I had mentioned will be a fluid document and we will use it as an implementation plan, but there is flexibility to kind of change things as we go to respond to, things that are unexpected or new things that we're not thinking about right now. I'd mentioned an individualized plan, just kind of a list of things that are going to affect the timeline. Obviously, if a hub is onboarded with Vibrant already or not, for example, your provider Frontier, they already are, so that would be a faster in your region. Establishing that backdoor access number for providers, regional dispatch protocols, kind of what those look like. We've HCA has received those from each of the ASOs, and they look really different by region, so that's going to affect things. There's an acuity guide that's being completed, and then how long that takes to be implemented. There's a lot of data sharing agreements that are going to need to be in place with the future state system. I had mentioned porting the RCL number and then also 988 geo routing issues. Um, and then just, public awareness and getting the word out to the public. And we don't expect it's going to be a deluge of, we turn off the number and all of a sudden 988 has all of these calls. It's going to need to be somewhat of a phased approach. And then, of course, staff training, and then financing pieces and contracts. So those are all kind of the things that we're looking at that will affect the transition timeline. And that's it. That's what I had for updates. But I'm open for questions. And if no questions, then I can turn it back over.
Thank you, Katie. And then I saw some questions in the chat. Just wanted to make sure that those got answered. One of my sounds like Amy. It might have been answered. I think Commissioner Rosie
I'm trying to.
had a question.
As I was posing the questions, Katie was answering them.
Wonderful. Great presentation then. That's always
All right.
see.
Thank you so much. I appreciate the time. And please feel free to reach out if any questions come up or anything. Open door policy with us. Thank you.
Absolutely. Thank you. If no further questions for Katie, I'll go ahead and turn it over to the Healthcare Authority for some HCA updates.
Hey, good afternoon. It's not afternoon. Hey, good morning, everybody. This is Tisha Kirschbaum with the Director of the Division of Behavioral Health and Recovery here at the Healthcare Authority. I think if it's all right, I'm going to give just a couple of brief updates, and then I believe I'm handing this over to Martha Abbey to give some updates on 1813. Does that sound right, Martha?
Sounds perfectly fine.
Okay, great. But hey, good. Like I said, hello, everyone. Couple of things that folks might be aware of. I'm also happy just to take general questions. One of the things, at least within DBHR, that the past couple of weeks we have been really focused on is kind of some evolving requests from SAMHSA, and SAMHSA is the part of the federal government where we receive a lot of our federal grants from, like our block grants, so mental health block grants, SEPTers, also SOAR, and a bunch of other discretionary grants. With the new administration, they have given us some new guidance on how they are reviewing and looking at our grant applications. So we have been working through that process. We have just submitted, about 2 weeks ago, we submitted every 2 years, we have to submit our application for our block grants. And so we did that, and now we are waiting to hear back on our submission and our application. I can say that in the past, those grants were extremely stable. And I think with just the fluidity of everything that we're seeing in the federal landscape, we just have more questions to their stability than we have ever had in the past. So we shall see how all of that rolls out. Happy to take any questions that you might have.
Tisha, thank you for that update. Any timeline on when you guys would anticipate to hear any feedback from SAMHSA on the block grants?
Anytime now. We haven't heard anything yet for our block grants. What we have been seeing is some requests for some of our other grants, maybe some of our discretionary grants, and also our SOAR grant for some certifications on how we would be interpreting and applying the executive orders that have come out.
Thank you.
So we're working through that.
Absolutely. Any questions for Tisha before we turn it over to Martha?
So is it safe to assume then that our current block grant contracts are good through the end of 26 and then it's, I'm sorry, end of 25 and then it's 26 that we have questions about what'll happen?
Yep, you've got it, David. Because we apply every 2 years. And then we're always like, we have got, you've got 2 years to spend, 1 year's of funds. So absolutely what you just described.
Thank you, Tisha. And we'll go ahead and turn it over to Martha for 1813 update.
Hi, so first I'd like to apologize that I am not very proficient in Zoom. I've doubled down on Teams, but Zoom I'm still a little sketchy on. So I'm gonna try to share my screen. Please bear with me. Let's see here. All right. And my mouse is deciding that it doesn't like to work today. So anyway, so here we go. I just wanted to share a little bit. I think hopefully, you know, everyone's had the pleasure of reading 1813, which is it was House Bill 1813 that got passed in the last session. There are a lot of different parts to 1813. Luckily, I am not in charge of all of them. So I am working on the implementation of the last one, but so 1813 includes some of the following components. Working on the health authority, the healthcare authority will consult with the Department of Commerce and the Department of Health quarterly to plan and prepare for new and expanded services. Then there's also create a strategy for managed care reprocurement. There's also an operational plan for a tribal BHASO that will be created. And then lastly, by July 1st, 2026, managed care organizations will expand the current crisis delegation services, which currently are phone, mobile crisis, and in-home crisis stabilization services. So expand what they currently have to the BHASOs to include crisis stabilization facilities and crisis relief centers. So that is going to be an increase in what the current delegation is. And we are working on a plan for how the MCOs and the BHASOs will co-create kind of some of the guardrails for these delegation agreements. So in that, we have scheduled 4 different work groups. These dates have been, I believe, moved around a little bit. So we've got a clinical pathway group where we're going to be talking about how people flow through the system so that we can look through and determine when communication needs to happen between the BHASO, the crisis provider, and the MCO. We're going to be looking at delegation agreement oversight with how monitoring is going to be done, what kind of contract changes need to be made for HCA for both the BHASO and the MCO contracts. We're also going to take time to look at care coordination, to look at the roles and responsibilities between all of the different players to make sure that folks with serious who are in serious need of crisis services and ongoing care coordination get their needs met. And then lastly, we're going to be talking about quality monitoring. How are we going to evaluate how these delegation agreements are being performed over time and looking at outcome measures. So that is kind of our current plan for the fall, how we're going to help BHASOs and MCOs come together within these work groups to talk about concerns, create kind of some expectations, and hopefully make things a little bit more smoother when the delegation agreement time and the contracting starts to occur. So that's kind of what we're currently working on in my world. And I'm gonna stop sharing my screen. And if there are some questions or comments on this, I know that Spokane's probably working really hard on their clinical pathways, hopefully, and because those are now due on the 20th.
Yes, thank you, Martha. Some important work is being done on that and regionally, and we're excited for the upcoming meetings to kind of talk through processes a little bit more in depth on how this will look in the future state as we move forward with 1813.
Yes.
Any
Right.
questions from the group at all?
I do have a question. This is Robert Rosenkrantz, one of the Ponderay County Commissioners. And I know that, one of the points of discussion was that sort of carving out crisis services from the managed care system changes the nature. I'm reading from one of my comments, changes the nature of these services. And there's no guarantee this will increase access to care or result in more funding for the services. There are 10 independent entities operating as behavioral health ASOs with different policies and procedures, potentially inefficiencies for managed care organizations when trying to coordinate all this. So I don't know if that frames up my question, but what's being done to address those concerns?
Well, I'd like to first say that a lot, like the bulk of crisis services are currently being delegated now. So, like, as I mentioned before, phone interventions, mobile crisis response, and in-home crisis stabilization services are all within the delegation purview of the BHASOs currently. And this is adding in crisis stabilization facilities and crisis relief centers. I'd also like to further state that we are in the beginning stages of doing crisis stabilization facility growth throughout the state. I think we, and particularly with crisis relief centers. So we're in the process of growing that system. So I think that there's a particular unique time right now that making this transition, I think will be beneficial, especially for the new facilities, so that they are able to kind of start off in the new world rather than have to make a transition with payers. So that's kind of one of our hopes in this process. Also, I think that our hope is that by having more of a regional approach, I guess, to well, I'm gonna pause. Like, I think that it's important to just note that most of the services are currently being delegated, and then also look to perhaps with the more regional relationships. I think cutting down the number of payers and the various different ways that crisis facilities are being paid for, I think will also assist the crisis facilities in their financial stability. Teresa, I don't know if you have anything that you'd like to add on that.
Yeah, thanks, Martha. Teresa Claycamp, I'm one of the deputy directors within DBHR. I think you nailed some really good points. I will speak a little bit about funding. We've been concerned for a while that crisis stabilization has been underfunded, especially on the non-Medicaid side of the house. It's actually technically not an entitlement. I don't know if folks realize that, but it's an entitlement on the Medicaid side. But for the non-Medicaid side, it's really always been within available resources. And that can ebb and flow. The new crisis relief centers, that's a new model for us, and we're learning about that model. We're kind of still in that learning phase, and also got concerns that it's underfunded, especially on the non-Medicaid side, because with crisis relief centers, that model set up as a no refusal, right? Front door, and so that is essentially an entitlement, right? You show up in need and you need to be seen, and it needs to be paid for. So this is, folks are aware it's a decision packet season, and we are looking at crisis stabilization as one of our areas of priorities to see if we can make sure that that's more is funded in a way that is more sustainable. So I don't know, Tisha, if you want me to say any more about that, but we are looking at the funding piece for sure.
No, I think that was a good overview. Did we answer your question?
You You made a good faith attempt to answer my question. The sort of overhang, which I'll get to later when I'm talking, is that the funding piece is, I mean, the strategic landscape is not necessarily pushing in the direction of being able to achieve the objectives laid out, and a front door policy that opens into um, an underfunded, interior that's problematic. So I give you full credit for the objectives that have been laid out and the means by which you want to achieve them. Looking at, these multi-billion-dollar deficits, it's just hard for me to say, yes, this is all going to play out as forecast simply because the resources that are going to be necessary to make this happen, to me, that's going to be a hard ask.
Yeah. Don't deny that. Thank
I
you.
will also say that Teresa and I are working with the Office of Insurance Commission. There is I don't know, Teresa, do you remember the number? I'm thinking 1688 from previous session that requires all private insurers to pay for crisis stabilization facilities and crisis relief centers. So we're working with the Office of Insurance Commission to make sure that the private insurance is carrying their weight in this system as well. So I just wanted to put that out there that like it's in this is not Medicaid only solve. I mean, we have to look at making sure that there's funding from all different potential payers.
Right. Just one more comment. Having spoken to some of those private insurance companies recently, they have repeatedly pointed out, we just pass it through in rate increases. So there is no sort of easy glide path into more money without someone paying for it.
True.
And Commissioner, this is Justin with Spokane. This has been a topic of concern of our region for quite some time, something we've talked about, and I know that it's something that we have attempted to build and support in the last couple of years, just to even maintain existing services. As we know, workforce has been a challenge, and especially in Ponderay County, there were a time where we almost lost all crisis services because of lack of workforce. So that itself adds to some of the challenges we're experiencing, even to maintain existing. I'm thankful and very blessed to say today we have been able to, with the work that we've done in the past in conjunction with HCA, to provide a supportive system. So what you're seeing now in terms of the ability to provide crisis response services for behavioral health throughout our region has and is meeting the existing crisis need. I think the challenge we see with 1813 is there is also a need for other areas, not just responding to a crisis, but where do they go? And practically speaking, in our region, with the loss of the stabilization facility FBH had because of a loss of census of individuals not being able to maintain that, we actually have limited resources to actually provide this. Practically speaking, you won't see much change in our region. We only have one stabilization for mental health services in Pioneer, and that's in Spokane County. So practically, even adding the service may not additionally see a significant change in Ponderay County or Stevens County, or even in Adams County right away. We are working on bridging those gaps in other areas: transportation, engagement, response, and increased mobile crisis services. Our region has also expanded out stabilization. And I want to note, in all of these services, although Spokane County Regional BHSO has taken the lead, our partners on the MCO sides have supported us continually to help expand those. So they have been at the table. And as Teresa and the team has indicated, though, there is still a challenge for that non-Medicaid side within available resources. And Spokane County Regional BHSO is one of the only ASOs that continually utilize those available resources for non-Medicaid outside of our required services. So we are actually doing quite a bit, and I know that our region has seen that. I think the reality, though, is there's still a lot more that's needed. And that is why Spokane County has invested so much in the new relief center to expand out that resource at our SRSC facility. I know that David and his team have also reached out for a grant to expand out stabilization services up in the northern region. And we do pay for a set of facility or in community stabilization services that we expanded out in recent years with David's team as well. But the reality, I think, really what you're speaking to is we see, and even if money is available, how does that practically look when it flows out to the communities? And that's a challenge we're still looking to overcome. I still can't access, and I think you know this better than anyone, facilities that may be providing that on the west side, because we can't even get people up to respond and then get them across the state. So as we work with our partners, are looking at all areas to bridge those gaps, recognize that funding must be of all partners to the table, which is why we're actively working with OIC and one of the few ASOs to actually have established contracts with commercial payers. And we're actually looking to see a couple more of those, because the reality is we shouldn't be subsidizing it, but all paying fairly to provide the stand and ready to go services. So again, I don't have a quick answer for that. You and I know it's a much harder, more complex response. However, I can tell you that it has not been lost on me, and our work has been diligent to address those gaps. And I think we have, and we'll have a better plan to provide to you as well as all of the electeds in our frontier rural communities in the coming months. Part of that is to transition so we don't lose our CL resources as we look to take on 98 and more of centralized response for mobile, which has been part of our big focus, but encapsulating also that expanded 1813. And I know, again, a lot of conversation is still ongoing with our managed care organization partners, and they have been active at the table with us to have those. So wish we could give a more clear picture on that, but more to come on it.
And let me close this part of the conversation with, I do want to express, I am grateful for this regional approach. And I know that Pend Oreille County probably disproportionately benefits from this regional approach. So thank you to all. I'm simply expressing, some of my anxieties and frustrations and the looking forward towards how do we align this deep unmet need in a landscape of challenged resources. So thank you for, as always, Justin, you're very diplomatic in fielding my somewhat cranky questions. So thank you.
No, a very important and vital question that really, this is something I continue to share to the state as well as representatives. Our frontier rural communities remain underserved and underfunded for the critically necessary services that are needed. The challenge is, how do we answer that question within the available confines we have both in statute and the funding requirements that the state has put on us? And I know HCA is just as challenged with those questions as we are. And I wish I had a pot of money I could throw out there. I mean, we still have the issue of how do you maintain long-term sustainable emergency response services? I mean, that's still an outstanding question that if you don't have someone to pick them up, then it doesn't matter how many services are available, they can't get to where they need to go. And if the hospital's not there and have available individuals respond, then so those are the key areas I think in a larger question we still have out. Are we, and is the future we want to invest in both nationally and in the state for providing necessary funding for our rural communities? Is it there? And I think we still have a lot of work as a state and as a nation to address that question.
Well said.
But
I just have to say, I just benefited a lot from this whole conversation. So I'm glad you asked the question. I benefit from hearing the answers, and also just the dialogue back and forth. So thank you.
I've seen a few people come on camera. I know that there was a hand raised before. Are there any other follow-up comments, questions?
oh, I do want, Ariane, I see that you also added in this. And yes, that has been one of my big focuses, the expansion of the Crisis Relief and Sobering Center at the SRC facility, which, stay tuned, we'll have a new name for the entire facility so we don't have to use various acronyms. Forthcoming, the board will choose a name, but it will encompass the crisis relief sobering. So we'll have front door, immediate ready access, as well as stabilization, withdrawal management, and co-occurring services. Something that will have a comprehensive response, something I know Ariane worked with and helped develop initially, get the first step, and now I'm working on trying to close that package, and something that Teresa has heard me speak quite extensively on to say as well, on the need to incorporate it, and something that the MCOs have also heard me say that are part of the conversation. So yes, it is, and I hope to have a kind of a, well, the state knows this, Teresa knows this, it's going to have various braided funding sources to ensure that there is sustainability, and there are still funding sources for operational that we have yet to realize. stuff that I'm gonna call out Teresa again. We all need to join together in our ask to the state to recognize key areas, especially non-Medicaid. But even on the MCO side, identifying clear funding that is needed to ensure all members are served. So as we look forward, I want that facility, I want David's facility to come online, and I want pathways for individuals to get to where they need to go immediately, regardless of where they reside in our region. All things on our list to address in the near future.
Justin, any other questions on those topics? That was pretty comprehensive kind of roundup on all those areas.
Yes. Thank you for bearing with me on that response, everyone.
Is there anything else from HCA? Just wanted to make sure. Not seeing or hearing anything other on that end. And so if nothing further, then we'll move on to agenda item number 3, which is Commissioner Rosencrantz.
Well,
Oh, go ahead.
before we do that, my apologies, Commissioner Rosencrantz. I want to make sure that we have FBH, if they have anything they want to add on 988, because as you guys saw on this, FBH represents our RCL and 988. We have given updates on our region's ability to integrate a vertical system, which as you saw on the map, we're kind of unique throughout the state of having the RCL and our 988 provider current hub, not the finalized designated hub, but the current one who we're hoping to maintain as a finalized one, having a very unique response in our region. So one area that our region benefits, again, is that there's vertical integration, clear and concise engagement in the community, and a comprehensive engagement that has been built on the years of experience that FBH has brought. We have, I think, the premier 988 RCL integration and response, partly because I also developed a plan. So that's a shout out for our region, but not specifically me, because others help with that definitely. But I want to make sure that Kelly also has the ability to speak on anything you would like to add on the update that both Tisha, Martha, and Teresa provided on the 988 RCL.
Thanks, Justin. No, I don't have anything to, and I know Mike's I think he's on the agenda to talk a little bit about the dispatch, the uniqueness of some things we're doing in our region too. Is that correct?
That's for our regional crisis collaborative.
Okay. Ashley, I read your agendas. That just is what it proves.
That's a good reminder to everyone here that that's coming up. So thank you.
Yeah, not a lot to add except for, we are unique in that as the RCL provider and as one of the 988 hubs, and as also the provider of crisis services, we really had an opportunity to kind of pilot in a pretty vertical way. Best practices, ensuring quick response times. We did recently just get our endorsement for the mobile rapid response team. So we've been in a really unique position, and I know the regions are different. I was not surprised at all to hear every region's plan is different and looks different, as we know it would. And by the way, as one could argue it should be, right? Because our communities are all unique. I look forward for more to come. I'm with Justin and the comments that Commissioner Rosencrantz shared. We know that we have to get on the other side of the end of this crisis continuum, right? This whole somewhere to go. And Tisha, I think it's great that HCA has been so open and candid about we need to look at crisis stabilization at crisis relief centers, the funding models, how that catches up with non-Medicaid, because we know that's the next step, but there's concerns about funding, continued funding, ability to staff, all of that. And it seems more answers on the Medicaid side, but we're all really worried. And Tisha, I've shared with you, my bigger worry is about who will be not insured. So that's already a population, and that population is going to grow. And that's really the response. And I could talk all day long about my work on the commercial plans, talk to Justin all the time about the commercial plans need to be brought to the table. I just presented on this at the State of Reform. So I don't think anything's missed, but from the provider level, all the things that are important to the ASO, to HCA, we very much agree on the provider level too.
Thank you, Kelly. And then Arian, did you have a question on that?
I did. I was just curious, and Justin, as you pointed out, truly honored to be here today, and I think connectivity will play a part in this. But the one thing I wanted to ask you was, in this conversation, how do you see the really remarkable investment that FBH has done in co-deployed units, in really triaging in a voluntary manner folks that are coming to stabilization facilities so that they don't waive any sort of duration in their Medicaid, abilities? I mean, is that going to be further explored as part of this, or is that kind of coming alongside this? Just because we've seen just that be really impactful for the different really handshakes that first responders can do in getting people into treatment without those lags that sometimes come when you don't have any other options.
No, absolutely. And that's part of our comprehensive response to the crisis system. FBH knew of our plans to this many years ago to incorporate them to a greater extent. FBH had partnerships with WASPIC, funding with SPD and the Sheriff's Department, as well as the Fire Department on co-deployed teams. And I said, let's do more. So we have partnered and had the board agreed to, for the Spokane County at least, expanded co-response teams with SPD. Spokane Fire, City of Spokane Fire. We actually had also discussions with City of Spokane Valley Fire Department. Let me be clear here. Spokane Valley Fire Department, which is distinct and separate from the City of Spokane Valley, something that they always remind me of. So I want to make that clear here for the record. But they declined at the time. So that is something that we are having to fund locally. It is an ongoing conversation. We're also having the state to say long-term, is this something the state is going to invest in? But as part of that partnership, the funding for the crisis side is included in our crisis plans, which and our crisis funding overall contracts, which are supported by our managed care partners and the state. So it's a joint partnership, and we've very carefully braided these to ensure that that connection has occurred. The challenge is in our frontier rural communities, you have limited first responders and some that are volunteering. So having funding to designate them separately for this not only is a challenge, but it also takes away from the overall response. So what we're trying to do is there a way in between? And that is ongoing work. How do we ensure we don't take away from workforce availability in a community where one law enforcement officer is covering 400 square miles or greater, right, of territory, and they have to get there within a certain amount of time. So as much as we like telehealth or telecommunications, sometimes having a body on the ground on the site is absolutely needed. And that's a challenge, again, as we speak towards greater resource needs and just the geographical challenges of rural communities, we have yet to overcome. And I don't have a great answer. I could give you an answer, but it wouldn't actually solve the problem. But it's something that I am working on with our partners. So I'm thankful to say Spokane County has some funds available, and FBH has partnered with us, and so has the City of Spokane. But we need to do more, and we are working on that for our other communities. And Kelly, I don't know if you have anything else you want to add on that.
I just want to add one thing, and Tisha, I'm sure this has also been a topic of conversation at the Healthcare Authority. I think something that's also going to give us an opportunity to demonstrate in now the co-response being under the ASO is the importance of not creating shadow response systems. This is where you get duplicated efforts. This is where you get inefficiencies in the system. And David was just with me at a meeting where we talked about that. And so for us, we have some experience with co-deployed through our WASPIC contracts. And basically what we learned is our co-response teams are effective because they're integrated with FBH, who also has access to the crisis services. So for us, it's not a shadow. It's another response in the full crisis continuum. Where we start getting really inefficient and really discombobulated is when responses are outside of existing services. And David, I know you and I talked about this, and our counties work so closely together, but it's really just important that we remember we should not have all these shadowed response systems. I can't think of a better word, David, unless you can.
Wonderful. Thank you, Kelly. And thank you for the good question, Arian, on that one. Now I will turn it over to Commissioner Rosenkrantz to talk about regional health impacts. The floor is yours.
Thank you. I appreciate it. And Justin is so diplomatic, but I will ask that if my thoughts become too chaotic, you simply flash that sign and tell me to get focused again, because so much of the last few minutes of conversation has added to what I wanted to say. And I'll start with the emergency medical services issue. I mean, yes, those first responders, that's a vital link to get people to where they need to go. Pend Oreille County has been trying for 8 years to form an EMS district countywide. I've picked it up over the last 2 years. And Justin stated it far more diplomatically than me, but fire districts don't necessarily play well together. They really like their independence, and getting them to see the bigger picture and agree to sort of join forces. It's challenging. They do it at a tactical level really well. Operationally, they do it really well. From a big picture perspective, it's been a little slow to get there. Pend Oreille County will get to a vote. I'm betting on this by the end of this year, whether to form the district. I'm voting yes, as long as I can get the bylaws created in a reasonably coherent way, which I believe I can. Let me get to my next set of comments with the backdrop of what has sort of fueled me for the past few months, and that is as the federal legislation was taking shape. Earlier this year, I read the Medicaid provisions and was really, really concerned, especially in a state like Washington, which to be competitive for those $10 billion over 5 years, it's going to be a hard lift. And if you look at the downstream impacts to something like Newport Hospital and Health Services, which stands to disproportionately be punished by the new Medicaid requirements, it could have a significant negative impact on Pend Oreille County. I picked this issue up fairly early with Congressman Michael Baumgartner's office and his local representative, Pend Oreille County. I'll simply say I have been disappointed at the responses that I've gotten. I got a couple minutes with the congressman himself at one meeting. And I took a lot of time to craft the email from the bill itself to point out where I found what I found most troubling. I was promised staff out of DC that are assigned to healthcare would get back to me. It's been about a month. They haven't gotten back to me. Not to get too political, but I'm a Republican. He's a Republican. I would have hoped there'd be a little more sort of a robust response, but I've gotten nothing. I will get to my request for this group in just a minute. Senator Josh Hawley out of Missouri has made a proposal to backfill the deficiencies of the federal legislation regarding Medicaid, increasing the total number to 100 billion over 5 years. By the way, the paragraph in the bill after the Medicaid provisions is increasing with 2 sentences. It increases the federal debt limit by $5 trillion. So I'm a fiscal conservative, but I'm thinking, okay, healthcare is pretty important. If you're going to increase the federal, debt limit by $5 trillion, add another 50 billion over 5 years to actually address one of the primary duties of government, and that is to make sure that its citizens have access to healthcare that allows them to. And now I'll get to the really important point that Kelly Miller made, which is that if you get people off Medicaid, the next step is being uninsured, and the cost spiral of them winding up in emergency rooms can blow the entire system up. So excuse me for ranting, but sort of my frustrations with the lack of a willing partner in Washington, D.C. has sort of gotten me hot here. So let me go towards my proposal to Congressman Baumgartner has been do a companion proposal in Congress similar to what Josh Hawley from Missouri, and that is it can be a 2-sentence correct, addition. $50 billion over 5 years is added to what the original bill proposed. It shall be block granted on maybe a pro rata basis to rural hospitals, avoid the bureaucratic, quicksand that might come from, well, yeah, but we want proposals for how to gain efficiencies. And it's like, no, just block grant it to the hospitals. Rural hospitals are really efficient to begin with because they have to be. Okay, let me close that loop and I'll come back to my request to this group in a minute, because I want to point out that one of the talking points that the very high talent capacity CEO of Newport Hospital, Kim Manus, is going to make on Thursday, September 25th, to Washington State Senate Majority Leader Jamie Peterson, pretty powerful person who is coming to Newport. I worked on that relationship for a long time. I had a personal connection. He very graciously has agreed to come to Newport and to see Pend Oreille County. He's never been to Pend Oreille County. We need to build those relationships to make him aware that the other parts of the state that he might not be as familiar with have needs that need to be addressed in ways that are simply being unmet currently. So I put that out there because if anyone who wants to zoom in or attend Thursday, September 25th, 10 a.m. to 12 noon, Majority Leader Jamie Peterson will be in Newport. Kim Manus she's invited, she's agreed to speak. She'll address many of these issues. I believe that the county commissioners, I'm only one of three, I've agreed we're gonna address issues that have zero fiscal notes and let the money asks come from people like Kim Manus. So where am I going with this? So I've kind of vented enough. My request to this group is if there is any desire or willingness to align with me on making a concerted push to Congressman Baumgartner's office on this, you need to pick this issue up. It's not going to go away. And here's the two sentences that I would ask you to introduce in companion to Senator Hawley's push. And if this group has any interest in doing that, I would welcome the collaboration with that. I have talked enough.
Thank you, Commissioner Rosencrantz. I think a very important topic that, as you can see from our conversation today, affects us all and I think is on all of our minds as we look towards the future. Any questions or thoughts or comments for Commissioner Rosencrantz?
Well, Commissioner, as Justin, I always have thoughts and comments, but I'll keep mine succinct as well. This is something I've talked with our Board of County Commissioners because although we recognize the disproportionate effect and to a greater extent that rural hospitals and rural healthcare faces in light of recent challenges to our federal economic outlook, especially as it pertains to some of the budget changes, it also impacts Spokane County and urban centers because when individuals can't receive the care that they need in the hospitals, they get more emergency care in the next trauma centers or local hospitals that can take them, which ends up being Spokane County. And the impact is great. It means we can't get them back home. It also means that there is more long-term care that needs to be provided. And it takes up additional resources when they can be better served and less chronically in their home communities. And that's something that our commissioners are currently evaluating for the next state legislative session, but it's something that we just identified in our federal ask as well. Can we evaluate and look at healthcare as a key area that there's bipartisan support to recognize that disproportionate impact for healthcare impacts everybody and rises costs for every aspect of those lives for individuals. So it is something that I will continue to push for our commissioners, something that, again, I can't speak on behalf of them. And I know Commissioner Cooney's not here, but it's something that is part of their focus. To your point, what is the best ask is still the thing on the table. And it is something that since Baumgartner did come from Spokane and has worked with Spokane County, they also have a unique relationship. And so something they're examining. But I also think it needs to be a state ask. And that's something we are going to be pushing towards our state representatives to say, how can the state of Washington work efficiently with the federal government to align our asks from a bipartisan support as well?
Very well. Just one additional component on September 25th, when Jamie Peterson is in Newport, State Senator Shelley Short will be there as well.
Excellent. That's something I'll remind our commissioners and elects as well.
Thank you.
Thank you, Commissioner Rosencrantz. No other topics or questions on that topic. We'll move on to item number 4, which is an update from Ryan Kent, Executive Director of STARS, Spokane Treatment and Recovery Services. I'll turn it over to you, Ryan. And you're on mute, just FYI.
There we go. Can you hear me now?
Yes.
All right. I don't know how much time I have, but thanks for having me. I think that considering the topics that have been talked about today, I think this is a good time to give an update about the STAT program. Just wanted to talk a little bit about numbers to begin with, and feel free to ask questions at any time if you have any. Currently, right now, we are, for the month of September, we've already seen 44 patients. Um, and out of those 44, 22 have been walk-ups, which is a big increase from what we were seeing. People on the streets are starting to walk up and come into the to the unit on their own.
Ryan, can I just pause you there? It might be helpful to give an overview of kind of what the STAT program is. I think locally there might be some awareness, but not necessarily for our whole
All
region,
right.
everyone in the room. If
Perfect.
that's helpful.
That absolutely. So the STAT program is a program that STARS and the county work together on to bring both sobering services, which is a 23-hour and 59-minute service for individuals that are intoxicated or under the influence of drugs or alcohol, or individuals that are in transition from, say, from stabilization to treatment, sud treatment, or something like that. So it's a unique program. STARS offered sobering for a really long time. Unfortunately, we had to shut it down for funding reasons, and with the county's help, we were able to get it back going again, along with the triage part of it. So the triage part is, I think, a really innovative way to approach a lot of the topics that we've been talking about today, or just a cog in that wheel, I believe anyway, as a referral source, for individuals that may be on the edge of crisis, but maybe not in crisis, and don't have somewhere to go, maybe would normally go to a crisis stabilization center, just out of habit from the police department, fire department, or whatever else. There's another option if they are not fully in crisis. And so the program offers various different types of case management. For example, I believe this month we have served 12 of the individuals that have come in the last 11 days for MAT services, MAT or MOD services. So they've been connected with a provider, they're receiving services, and they will continue to receive services. Other things like individuals that are qualified for Medicaid and do not have it, we will set them up with that as well, so that they have insurance and can move on to other levels of treatment. One of the big parts of the STAT program is it is located in our new Cali facility building. And it is convenient in the way that once a client has gone through sobering and triage, if withdrawal management is the correct next step for them, then all they have to do is walk upstairs and they are in withdrawal management. So uh, there's no transition in that aspect where they have to have transportation or have to walk somewhere or wait a few days to go somewhere. It's directly into withdrawal management, and from there, they have the opportunity to either stick with STARS and they can stay with us on up through all of our programs if they meet levels of care, and can potentially get care up to 2 years if needed and approved by the MCO. So a big part of the STAT program is the continuum of care. It's a first step for SUD and co-occurring individuals. There really isn't a whole lot of options for people that are intoxicated and under the influence currently, you know, other than the hospital and I believe stabilization, but it's typically people wind up in the hospital when they're under the influence, and you know, our goal is to divert as many of those individuals as possible, and keep those beds in the hospitals freed up for the individuals that need them. So that's a little bit of the overview of STAT. We serve pretty much anyone and everyone within the region. So people can come in from all over. So got a few other things still. I'm not sure how much time you want to spend on this, but I can talk a little bit more about some of our numbers or some highlights from the program. We are getting ready to start renovations on the Cali facility, which the STAT program right now has already been renovated and is a really nice therapeutic space, but it's going to be improved upon even more, which is really exciting because it's a really nice place at this point. And to go along with that, the other renovations that are being done are in the 3.5 level of care, which we haven't offered in the past. So that's another level of care that will be provided in the same facility that individuals that come in through the STAT program can be referred to without having to step outside, which I think a lot of us know that when somebody has a bed date or needs to transfer to another facility for treatment, oftentimes they get lost in the mix or drop off or start using. So that's an advantage when it comes to success rates.
Thank you, Ryan. And just from the county's perspective too, so STARS was selected as one of the recipients of the county's opioid settlement funds. And the strategic plan centered around that, part of that being the build out of the crisis relief and sobering center, which we know will take time. And we know that there's an immediate need in the community. And so STARS was selected to initiate this new program, the sobering triage and transition services, which, you know, speaking to Ryan's points, really is helping identify those individuals that otherwise would be being taken to the hospital and not having kind of that more treatment specific and centralized need being addressed in the lowest level of care necessary, that outpatient level of care, and connecting individuals to there. And this has also helped us really gather what are some of those barriers after someone receives that initial care to getting onto that next level or next type of care that they might be appropriate in for that individual. So I appreciate you speaking to that, Ryan. And through that partnership, we're able to partner with STARS and with Department of Commerce on the purchase, I know, of your guys' building to be able to long-term be able to provide services in there. Justin, is there anything you want to add on that? Spokane County? No? Okay. Any questions for Ryan? I know STARS has served almost 1,000 individuals since December, which is pretty significant number. So we're looking forward to kind of seeing how those trends continue in the future with expanded access through a partnership with the city of Spokane and Spokane County to expand bed availability.
Absolutely. Thanks for having us, and looking forward to the continued work that we're doing and with you guys.
Thank you, Ryan. Thank you very much. no other questions or comments on that, we'll move on to item number 5 here, which I'll hand it over to Arian Schmidt, the Executive Director for Broadlink, to talk about the public benefit broadband update.
Well, good morning. Really honored to be able to share. I know several faces. I know several of the faces of your predecessors or your benchmates, and Justin may know this, but I am probably one of your biggest fans. You guys may not know this, but I talk about the integrated managed care system, the regions, what you guys are doing as trusted, reliable, and outcome-based entities for individuals all the time in the broadband space, believe it or not. And I really think that as there's a lot of crunch going on, you guys articulated that well, that this is really the call to arms to really link arms with one another. And as different types of solutions are coming out, what you guys have established, what your other, what is it, 5 cohorts throughout the states have established, I routinely bring up the IMC map and say, this is where we need to put digital health and navigation solutions, because it's the same people that are seeking the care that you're giving that need to understand what digital literacy is, digital access solutions. So just know I actually talk about you guys all the time. And it's just amazing to see what's going on in the community, in the frontier areas, because really connectivity and care share a lot of similar situations where that lack of density, that distance barriers, really the things that keep people from being connected can keep them from connecting for care as well. So I wanted to first share, those of you that don't know what Broadlink is, we're a public development authority of Spokane County. We're one of 5. We're 2 that share a countywide extent. So what happened in 2022, the commissioners decided they were getting out of the business of broadband. So they picked up a collection of state statutes and said, we are going to create something that gets up every morning trying to figure out what is the nexus of public benefit, connectivity, and partnerships with internet service providers throughout the region. And not unlike you as care providers, it's really those public-private partnerships that cross that gap, that where things like return on investment or ongoing M&O hurdles really seem insurmountable. We're finding, at least in the broadband world, that has been the missing link that has created some really remarkable things with entities as big as Comcast to as small as mom and pop broadband providers, to bring what I think we all realize, that affordable, sustainable, and competitive offerings to our rural areas is really what undergirds resiliency. And so as we do talk about funding, I guess I have the very unique situation of being in a place where funding is still very vibrant and very active at the federal level. There's a $42 billion allocation by Congress called the Broadband Equity Access and Deployment Fund, called BEAD, that cleared all the reviews, for lack of a better word, and is still going out the door to the 50 states and territories. Washington State received allocation of that $42 billion of $1.24 billion. Spokane County receives about an allocation of $120 million of that $1.24 billion. All of that comes down to eligible addresses that fall below the minimum standard of what the federal government has classified as what is needed internet. And that comes out of COVID, that if you couldn't work from home, learn from home, have access to at least nominal services for health, behavioral health, and mental health, you didn't come out of COVID well. And I agree with Justin, there's nothing that replaces face-to-face, but there is an element of having that connectivity that either as a precursor or follow-up to the face-to-face can make or break what your next step is. So what I'd like to share is first in Spokane County, and then because we have definitely other counties involved, a little bit about where that is, and then a few others kind of solutions coming down the pike that, again, I had you in mind when we were creating this. So of this BEAD funding for Spokane County, We're really fortunate that Broadlink is sitting at about 13 of the 24 areas that are receiving funding that totals about 90 million to bring internet to the about 20,000 eligible addresses. Now that doesn't mean we're gonna stop at 20,000, but those are all that, in my mind, don't get broadband PBS. And that absolutely is replicated over many areas throughout the state, which I'll show next. But the key part of this is, and you might be been hearing this at the federal level, is it fiber? Is it fiber? Is it fixed wireless? Is it low orbit satellite? And there seems to be a lot of tit for tat in that, but it's all of the above. Basically, each type of connectivity really depends on the other. Fiber is needed to connect to towers. Believe it or not, low orbit satellites calibrates to towers to bring delivery. And really, you need to understand what you have for funding, what are the people you need to connect, and really, how can you do that in a way that's resilient and vibrant? And so throughout Spokane County, because I affectionately call us topographically and geologically challenged, we have to employ all of them. So we will be managing that going forward with a number of other entities that are also providing solutions. But I also wanted to show, just because we've got other counties involved, what's going on in Pend Oreille, in Stevens, in Ferry, in Lincoln, in Adams, and Whitman. This is a high-level view of basically the focus of where the people live and what types of technologies are going to be allocated throughout the state to bring internet, which then comes right alongside digital navigation solutions, digital care solutions, hospital to the home monitoring solutions, aftercare. So as you see here, as Commissioner Rosenkrantz saw, there's a lot of fiber being put into Pend Oreille County. Stevens County is actually really embracing fixed wireless. Ferry County, again, has an amalgamation of fiber and wireless. Lincoln County, and real hats off to Lincoln County as a real front runner in this, is really employing a combination of hybrid from what they've already done in bringing internet to their small towns and cities. And then again, Spokane County is really traversing a lot of ground with the focus of fiber where it makes sense and wireless where it doesn't. And I do want to kind of focus in on this area up here, which is the Deer Park area. As we go forward, we're really braiding, not unlike Justin said, solutions. So this is one solution. It's got a very, very fast timeline. Everything needs to be expended and deployed by 2029. So there's a lot going on that just got out the door. But we are also working on some other aspects. One in particular is with USDA in a Community Connect project just south of Deer Park, of which we are required to operate for 2 years a community center. We didn't want to have the obligations of a brick and mortar, and so we asked USDA if we could try something unique, and it's called a community center in a box. And think of a very large Connex that has a telecommunications room. We've spec'd it out to have 3 HIPAA compliant meeting rooms. It will have a 120-foot tower on top of it. It will live next to a fire station in North Spokane County for the 2 years of the grant. And but after that, it will become property of Broadlink and will be available to move anywhere. So that means if in Stevens County in Clayton, there is a meth crisis, we can move that there. If you need something that needs to have a mobile methadone clinic, if you know, all of those types of things, this can be something that can be utilized where an asset is needed and you're not sure how to get what you need there to provide the services that's really critical either in care or in response. If we, heaven forbid, have another Gray and Oregon fire outbreak, this could become the emergency operations center. So there's a lot of things that we hope will just really braid alongside connectivity of households and businesses and anchor institutions to essential services. A lot of our work will be connecting fiber to the Spokane County owned towers that deliver the E911 notification. Right now, those operate on the equivalent of like a coffee straw where we're going to be putting in a fire hose. That's going to help our first responders get more information from dispatch, whether that's automatic vehicle location, whether that's medical determinant information, whether that is things related to wildland fire response. So again, I don't know what it is. That's what you guys are talking about, but I'm going to bring the new essential services to make sure that it's there when it's needed to come alongside the things that make your basically required services to people even better, knowing that digital robustness is available. So that was really kind of my recap. Again, this is going to be ongoing in motion. Any of you are welcome to attend our broadband action team. We facilitate the one for Spokane, but I work very closely with the Ponderay Broadband Action Team, the Stevens County Broadband Action Team, Whitman County. So again, really just very grateful for the time to share about things in the digital space today.
Thank you, Ariane. What a great update and very important. And thank you for connecting that to the services and the things that we're talking about here. It's all interconnected. And if you don't have any connection, then it's hard to even have a starting point. So really appreciate the work you and your team are doing. I do see a question in the chat as well, asking about how someone identifies if they qualify or to apply for support. Can you speak to that at all?
Absolutely. And this is one that I think is very important. We had the honor of having a federal FCC commissioner in Spokane just yesterday, Commissioner Gomez. And many of you may be aware that there was a federal program called ACP, or Accountable Connectivity Program, that went until 2024. And that would be what I consider the digital equivalent to a food stamp or utility bill. That timed out at the federal level, and that was really the gold standard for, as my household income put me at a level where I qualified for subsidy, I immediately got a voucher that let me apply that to my broadband plan. That right now has gone away, but again, we are actively in the process of starting that up at a local level, so that again, as someone comes to you or to your services and qualifies, there's just another checkbox, and that we can then come alongside the ISPs for that. I do know that Comcast still has a subsidy program. There's 3 or 4 others, but I'll put my email in the box, and we can. Again, we're trying to limp along until we can get a new pilot in place. We did speak with both City of Spokane and County Community Services, because HUD now requires broadband in the consolidated plan. And that means that maybe after entitlement funds have gone through solicitation and you have a little money here and there, let's put that into a local ACP plan so that you can continue to have these things cycle through, be it sustaining alongside other digital assistance. But at the end of the day, you can't have subsidy for your internet plan until you get internet in the first place. And so that's what we're really focusing on, is in a number of areas in the county, we're trying to fast track what's called the fixed wireless, which is high capacity point-to-point wireless that is being deployed very quickly. We have a deployment right now in Elk, actually just north of Elk, the Deer Park Water Tower, Medical Lake Water Tower, that again, we want that in place. And then as we build fiber, that can obviously then replace the fixed wireless for the folks that then could transition to the fiber. So unfortunately, it's not a clean yes, no. It's a journey that we are going to be doing at a sprint pace. But I'll be happy to put my contact information in there, and we can just really come alongside you, so that as we know the folks that are going into outpatient, that we can do our very best to make sure that they have connectivity, to make sure that those really important virtual appointments get attended.
Thank you, Ariane, very much. Any other questions or comments? That was your comment. I was like, we've got a comment. No, thank you for putting that in the chat. Super helpful for connection there. As we are almost at the end of our time here, we will give a brief update on our regional BHASO updates here regarding the crisis system updates. And a lot of those have been discussed today. So a lot of work is being done on 1813 and kind of the future state of what that will look like. As Justin, Kelly, and DOH and HCA discussed with 988 and RCL, our region is unique and has already been working on streamlining that response and dispatch through our mobile dispatch unit, which we've talked about here before, and that work is ongoing. But we are working with the state on a new way to dispatch to ensure that the information coming into those lines helps our crisis responders triage those cases to know which ones need a response more immediately. And part of that is adding in a new type of response, which is a behavioral health emergency. And that was added in with the endorsed teams. And as Kelly identified, Frontier Behavioral Health did receive their official endorsement as an endorsed mobile rapid response crisis team as of August 1st. I know that was a lot of hard work by Frontier to get everything completed during the application process for that. And so they are live with that. And the reason for that is to streamline those responses for individuals that need an immediate response in the community, not meeting a threshold for first responder type response, or maybe, you know, a paired response would be appropriate, but really getting our responders out the door to those individuals as soon as we can, as a part of SAMHSA's someone to call and someone to respond. And as Justin talked about, we're still working on the someplace to go with the build out of those facilities. And that kind of leads us into the next bullet point here on new inpatient facilities updates. So
just something to add on that, because I know the question comes up. What about the connection and engagement with our Frontier Road communities? We talk extensively about Spokane County, and I just want to assure both for all the individuals here in our Pend Oreille, Perry, Stevens, Lincoln, and Adams counties that we're working very closely both with our crisis providers in those regions, the local community hospitals, law enforcement, and other partners to ensure that any source of connection or coordination for those services are ongoing. And Commissioner Rosenkrantz, we've met quite extensively with the hospital and the local partners there too to identify how we can best support and inform the work that they're doing. That's imperative to ensure that the services are meeting the need, but they also have clear identification when those resources are
out there or available.
Exactly. So that they can utilize them. But there's still a lot of work that needs to be done. And David's been here with Stephen County longer than I have. And he and I have dealt with a lot of issues over the years. I can say safely and confidently, I find myself in a weird position where workforce used to be our biggest issue. And now it is just the recognition of previous issues before workforce were in place where we still don't have enough resources or response, because workforce, we've actually done great strides in addressing. And in fact, we have gotten better at even our payment parity for crisis providers. The challenge now is we still have historical lack of resources in those regions that identify the unique geographical issues that we face in those regions. And so as we work towards those, again, part of the reason why we have Ariane coming to speak, we're looking at all areas where solutions can be made to bridge that gap. So I just want to be clear on that. That is not something that's lost on me. And as an individual who was raised in Okanagan County, shout out to Brewster, go Bears. We still have the challenge associated not only with my family who currently reside in rural communities, but all individuals, that this challenge that we are saying is there. Communities are filling that need, but the simple reality that they have always had to maintain and take care of their communities. So although we recognize that, it's getting them the tools necessary and recognizing they lead the conversation to better support and identify where those needs are in their communities. So we're doing that, we're listening to that, and working with the correct people at the table.
Absolutely.
But again, no easy answers. And I don't think there's something that Justin, even though I wish I could, solve overnight, but maybe forthcoming.
Forthcoming, exactly. And we put on here just an agenda topic of new inpatient facility updates, as there's been a few identifications of facilities that may be coming online here in the near future. I'll talk about two that we currently are aware of here in Spokane County, and then the regional impact of that. And then, David, if there's anything that you want to say regarding the efforts that you guys are doing also on the stabilization facility up in Stevens County, that would also be a welcome, not to put you on the spot or anything, but addition to the topic here. So multi-care, Deaconess South location has been awarded a grant through Department of Commerce, and they are building out an inpatient psychiatric unit within their hospital. And so don't anticipate that to come online till the end of 2026 or early 2027. So still some time on that, but just wanted to bring that awareness to the group. And then the local.
Actually, is that going to be an ENT or a psychiatric hospital?
Psychiatric hospital.
Okay.
Yes, within the hospital.
For adults.
Correct, for adults. And then Man Grandstaff Veterans Administration Hospital here is exploring the option of taking veterans that are on Involuntary Treatment Act orders. Currently in the state, VA Puget Sound on the west side is the only VA that is taking our veterans that are on involuntary treatment orders, and locally they are evaluating that capacity to do so and working on that diligently. That will have an impact through all of our crisis services, as there's provisions of the statute which require our designated crisis responders to seek out placement at a Veterans Administration for veterans if they are exploring voluntary or involuntary options. And so we will keep you apprised of updates as we become more available, as those become more available to us as well.
Hey, Ashley, just really quick, if they would like us to have a DCR come out and talk to them about what an ITA process looks like or what they can expect, all about it. Getting our veterans on the other side of the state is typically not accepted. We need to work on keeping them in Spokane, so, or in surrounding communities. So happy to help with that conversation. Just reach out.
Yeah, absolutely. Thank you, Kelly. And I know that Tanya's been a part of some of those early
Yeah.
conversations as they were exploring this. So
Yeah.
I'll definitely ensure you guys.
I'll send Shelby right there. Have her talk all day long about it. Yeah.
Wonderful. Thank you.
Yeah.
And David, would you like to provide an update on where you guys are with your stabilization facility?
Sure. So last year we applied for a commerce grant to build a licensed crisis stabilization unit, actually in the building that's right next door to our main outpatient location in Colville. We were awarded a $2 million grant, and I'd hoped that that facility would have been opened by now, but we ran into a challenge on our conditional use permit. A local business challenged that we put the facility there, so we actually had to go to court, which slowed us down about a year. We prevailed in court and have the conditional use permit. We've since contracted with NAC Architecture to design the renovation for the project. We're moving full steam ahead on that. We anticipate construction will start around December 1st. And just yesterday I was looking at our finish timeline with our architect, and they have said September 18th, 2026 is the date that we should have certificate of occupancy and be fully licensed. So about a year from now, we will be opening 14-bed licensed crisis stabilization unit located right next door to our main outpatient location here in Colville. So looking forward to that. 2 weeks later, I will retire, pass off the ball to Martha Fairley, who's officially been recognized as my heir apparent, and say good luck on the crisis stabilization unit.
Just in the nick of time. I know that's been a labor of love up there with a lot of back and forth, but very excited to hear that progress is moving forward in the direction that I know you had planned, having completed a year prior.
Yeah.
Unless I can convince you to stay, David, for another year. So.
You solve all the federal funding, Justin, and we'll talk.
Oh, I think we all agreed that was going to be Commissioner Rosencrantz's job.
Good.
Yeah.
Good.
David, I think
support
you
that.
want to reap the rewards of your hard work for a little while before you go.
I want to stand back and see what you do with it.
Wonderful. Any questions or comments on those final topics before we wrap up today? Apologies that we're 2 minutes over. Not hearing or seeing any. Thank you all so much for your attendance today. We covered a lot of different topics, a lot of important things happening federally, statewide, and locally in our region. So just really appreciate everyone's continued attendance. The next meeting is scheduled for Friday, December 12th. Any closing thoughts?
Great meeting. Hope you feel better, Justin.
I hope to as well. A lot of sleep this weekend, so.
Right.
Appreciate everyone suffering through my voice, and thank you everyone for attending. We apologize for Commissioner Cooney being unable to be in attendance today, but we'll make sure all the information is provided to the board and follow.
Thanks, everyone.
Thank you. Bye-bye.